And my talk really is mainly to speak about how do we clinically assess the patient and staging of the disease and the approach to the management of breast cancer. Sorry, that. So I think the outline of my presentation it's not, yeah, just like I've said, mainly the assessment, staging, and management. We'll not waste too much time on speaking about statistics. I think Dr. Brown mentioned clarified how much the burden of disease is both in Africa and the rest of the world. And I think for me, what I'd like to note on this slide is that unlike in other countries in South Africa, the age and stage at which breast cancer is diagnosed is different from different population groups. And the reason
Hi, Doc, please unmute. Thanks.
Oh,
Thanks.
yes, sorry. So unfortunately, that translates to the fact that patients who are in a rural province, for example, don't have similar access to oncologic service as someone else who's born, who lives or who is born in Gauteng, for instance. And unfortunately,
Dr. Tafana,
yes,
we have some bad feedback. I'm not sure if there's some noise there, but it has stopped now. Maybe it might be your mic or something.
Okay, maybe.
You know?
Okay, maybe it's the mic. Yeah. So unfortunately, this has an impact on the prognosis of the patient, as you can see in that slide. That early detection is really what saves life, because if the patients are diagnosed at an earlier stage of the disease, their likelihood of survival is higher. Yeah, as we've discussed previously, I think this has already been discussed. The assessment of any patient who has a breast complaint should include the triple assessment. We'll not go into a lot of details with some of the things that I've already mentioned. I will focus mainly on the clinical assessment and physical examination of the patient. But however, this is a very important slide in that any health worker who is approached by a patient who has a breast complaint, if the patient is offered a triple assessment, meaning a thorough history, from the patient, which will be focused on trying to ascertain if the patient has risk factors, as mentioned in the previous talk. You want to know as well, does the patient have any comorbidities that would have an impact onto your management? And then you move on to the physical examination. And the patient is further referred for imaging. And based on the imaging findings, the patient may require a histological diagnosis. And that's when you would decide whether you're doing an FNA, a corneal biopsy, or any type of biopsy. So in terms of physical examination, what's important is that here, the patient needs to be informed. Basics first, you would have to inform the patient this is what you intend to do. Like Dr. Brown, I think, mentioned it, that there's sometimes cultural differences. Some patients are feeling uncomfortable to undress in front of the doctor, and sometimes it makes them feel at ease if you'd explain to them that this is what you would intend to do. This is the clinical examination of the breast. The patient needs to be exposed from the shoulders to the waist. You have to examine the patient in both lying down in a sitting or standing position. because certain areas of the breast might be missed. If a patient has pendulous breast, you might miss the inframammary fold if you examine the patient only in the sitting position. Hence, you have to change the position. And just like any other clinical examination, this will have to begin with an inspection where you'd be looking at the patient's breast. Is there any asymmetry on the breast? Are you seeing, is there any visible lumps? Is there any nipple deformities that are obvious on inspection? Is there any skin changes? And all of those things get noted. And when you examine the breast, it's important to have a system that works for you. You can either divide the breast into 4 quadrants and examine each quadrant at a time. You can use a circular motion around the breast just to cover all of it, not forgetting to inspect the inframammary fold, as well as to examine the axillary tail of Spence. And that's the part of the breast that goes towards the axilla, as well as the lymph node assessment, examining the patient's axilla, both the ipsilateral and contralateral side, as well as supraclavicular and lymph nodes as well. Another important thing is that when with the breast examination, if there is a lump, the description of the lump, then you need to describe the location of the lump. Is it in the upper quadrant, lower outer, upper outer? Or you can also use the numbers on a clock to describe it at 2 o'clock or at 9 o'clock when you're looking at the breast, to describe the location of the mass, the size, the consistency. Is there any pain associated with it? Is the mass movable, or is it fixed either to the skin or the underlying chest wall? So all of that description is important when you note the clinical examination. So I think I've included the BIRAD score here, and I think Dr. Tebe will speak more about it because after the clinical examination, when the patient gets referred for imaging, the report usually comes back in this format, where they will use the BIRAD score to give us the radiological reports. And I like this slide a lot because this makes it easier for clinicians. Even if you are unsure what to do next, the radiological reports, the way that it's made, it assists you in what the next step in the management should be. For example, if the BIRAD score comes back and they say the patient has a BIRAD 2 lesion, and then you know that this is most likely a benign lesion, and follow-up is appropriate for that patient. But however, if the patient has a BIRAD 4C lesion, it tells you that this lesion is most likely to be malignant. Then you have to move on to tissue diagnosis. Then you move on to histological diagnosis. And once the patient is diagnosed or a diagnosis of breast cancer is made, then we have to move on to staging the patient. But for us to stage the patient, we have to assess if the patient has any metastasis or not. So when it comes to doing a metastatic workup, there's we use imaging to assess if the patient has any metastasis or not. Chest x-rays, if you do a chest x-ray, patient may have a pleural effusion or cannonball lesions, then you'd see there's lung metastasis. Bone scan, CT scan imaging, MRI, really whatever is more available to you. However, we are aware that chest x-ray is not as sensitive as CT scan if you are going to look for metastasis, lung metastasis, or even liver metastasis. However, so we don't routinely order all of the investigations on all the patients that are diagnosed with breast cancer. So patients who clinically have T2 or T1 and T2 lesions, who have clinically no nodal metastasis, these patients do not need routine metastatic workup according to the NCC and AJCC guidelines. However, if the patient presents with, for example, if they have what looks like a T1 or a T2 lesion, meaning they clinically looks like early breast cancer, but they complain of bone pain or they have you do blood test and they have an increased alkaline phosphatase or calcium, and then you're worried that there may be bone metastasis, then this is an indication to order specifically a bone scan for that patient. However, I'm noting that this is not a routine thing. Routine metastatic workup is indicated for all the patients with locally advanced cancers, such as lesions that are more than T3 or N1 to N3 nodal metastasis. When it comes to staging, why is it important to stage the patient? So when we stage the patient, so using both the clinical findings, the radiological findings, and as well as the histological findings of the tumor, we are going to stage the patient. And the importance of staging is that when you stage the patient, you prognosticate the patient, and then this guides you as to how do you approach the treatment, meaning patients in a certain stage are treated differently. It also allows you to cancel the patient when you can cancel the patient, so that you are able to adjust expectations from your patient as you begin with the planned treatment. So it's very important, and staging is done using the TNM staging, which uses, with the T stands for the tumor size, nodal metastasis, and the M for distant metastasis. I will not go through the entire thing, and depending on the T stage, the N stage, and the M stage, that is combined to form the anatomical or prognostic staging, which is then the stage 1, stage 0 up to stage 4, which is what we use to plan treatment for the patient, as well as when we cancel the patient. For those who are more interested, it's better to check the staging. There's some updates from the 7th to the 8th edition, which has more details. For example, in the 8th edition of the NCC and TNM staging, they've included the biological or molecular subtype of the cancer in the staging. And I'll explain further in the next few slides why. Because the previous TNM only looked at the tumor size, the nodal metastasis, and whether there was distant metastasis or not. And that was just TNM. But now they've included as well the molecular subtype of the cancer, the grading of the cancer, and you'll see in the next slide why they've included that, because it's also a very important prognostic tool. So I think Dr. Brenda spoke about this. I'm not going to go into detail with it. She mentioned the different molecular subtypes of breast cancer, and these are based on whether the tumor expresses estrogen or progesterone receptors, whether they are HER2 receptor positive, or they are triple receptor negative, and as well as the proliferative index, the Ki-67 index. And then it also in the tumor grading, the tumor grading, whether it's high or low grade. I think she's also alluded to that as well. So I will not go into detail on that slide. But what's the slide that I wanted to show you is this one, so that the molecular subtype is very important, because if you look at the molecular subtype and the survival of the patient, you'd note that patients who are luminal, who have luminal cancers. Luminal cancers are the ones that are ER and PR receptor positive. Those are the luminal cancers, and these cancers are thought to be those that have a lower grade compared to the other cancers. And you'd see that these patients have a longer survival compared to the patients that have triple negative breast cancers, meaning that do not express neither the progesterone, estrogen, as well as the HER2 receptors. So this is very important, and I think this is why this was included in the 8th edition of the staging, to better prognosticate the patient. My slide is not moving. Pardon me, just need to. Okay, and again, the molecular subtype is also important, because we've noted that different molecular subtypes tend to have different patterns of metastasis. And if you note that the luminal cancers, they tend to metastasize more to the bone as compared to the HER2 and triple negative cancers that have more visceral metastasis either to the liver or the lung. And this is important because we know that patients who have skeletal metastasis, so if you compare all patients with stage 4 cancer, those patients who have stage 4 cancer with isolated skeletal metastasis tend to have a longer overall survival compared to the patients who have visceral metastasis. So this also shows again that the patients who have other cancers other than the luminal cancers, their prognosis is poorer compared to the other patients, which makes the molecular subtype of the cancer a very important tool in the prognostication of a patient. And then now coming to the management or treatment of breast cancer. In as early as 1882, patients were being treated for breast cancer. However, from that time until now, the treatment has changed quite a lot because at that time, doing a radical mastectomy was the only treatment that was available. And unfortunately, a radical mastectomy was it was a surgery that was associated with a lot of morbidity and for the patient, and that was not ideal. But currently, the management has improved quite a lot, and with understanding the tumor biology, like I've mentioned, what type of cancer is the patient, what's the molecular subtype, understanding the patient that you are treating, as well as what comorbidities they have. The patients can be offered different types of treatment. They can be either offered systemic treatment, being either chemo or endocrine treatment or targeted therapy, as well as local therapy in the form of surgery or radiation. And the patient can have one of these treatment or a combination of treatment, as you'll see as we discuss. And very importantly, for you to be able to treat the patient holistically, a multidisciplinary team approach is very important. As you've seen, I think Brenda mentioned it, intraoperatively, you sometimes require a pathologist to look at sections for you to make sure that the margins are clear. And sometimes the radiologist is also required, not only for diagnosis, even intraoperatively. If you excise a specimen and you are unsure of margins, they can do a specimen mammogram or ultrasound to check if the margins are clear. So multidisciplinary team is quite important. And rehabilitation of the patient post-operatively, the use of medical and radiation oncologists as well for the chemo and radiation therapy. And the younger patients, since we have more and more younger patients with breast cancer, some patients still need their fertility, and we have to weigh the options as to how do we treat the patient's breast cancer optimally, and how do we preserve their fertility. I think we'll still have a discussion on that later. Then the mental health of the patient, if you are going to I think if you've dealt with patients, you'd be aware that as soon as the word cancer is mentioned, the patients, they assume that they are dead, and they don't know how to cope with it sometimes. And the assistance from mental health team is also very important. And not forgetting that the patient is not only an isolated person, they are from a family, they are from a community. So when you plan the treatment, you must bear in mind how all of this is going to affect the patient and her support system. And as the surgeons as well, the surgical team can include both general surgeons, specific endocrine surgeons, as well as plastic surgeons. And primary health care is very important at the beginning in terms of screening as well as diagnosis. So the management of breast cancer, for the purpose of treatment, we manage it according to the stage. And here it's easier if we group the stages so that we understand the approach to management. We group the stages into either early breast cancer, locally advanced breast cancer, and metastatic breast cancer. The early breast cancer will involve all the tumors that are less than 5 centimeters in the T stage, and these would either have limited or no nodal metastasis. Locally advanced breast cancer, these are the tumors that are more than 5 centimeters, meaning T3, and then they would have clinically positive lymph nodes, and they may or may not have involvement of the skin and the chest wall, meaning T4. And the stage locally advanced is also subdivided again into either operable or non-operable locally advanced cancers. And then metastatic cancer is the cancer that already has spread to distant sites. So in terms of stage 1 breast cancer, so I think, as I've mentioned, that previously the only treatment for breast cancer was doing a radical mastectomy. But currently, I think with all types of cancers, I think everyone is moving towards organ preservation, meaning you would try not to remove the patient's organs if you can, be it the liver, be it the colon, or whatever. Most treatment of cancers, all types of cancers, is moving towards organ preservation, and so is breast cancer. So if patients present with early breast cancer, stage 1 or stage 2A, the treatment for those patients include wide local excision, plus sentinel lymph node biopsy, plus adjuvant radiotherapy with or without chemotherapy and with or without hormonal therapy. I'll explain that again later. So I use the term wide local excision instead of lumpectomy to emphasize the fact that there should be margins of normal tissue around it. So, because sometimes if you say lumpectomy, it gives an impression that you're removing the lump only. So I rather say wide local excision. And then after the wide local excision and sentinel lymph node biopsy, the patient is either offered axillary lymph node dissection or they are offered observation. So in terms of sentinel lymph node biopsy, we do the wide local excision and sentinel lymph node biopsy, and the pathologist should be on standby to assess the lymph nodes for you. And then they would assess the lymph nodes if the patient sentinel lymph node biopsy, which is the first draining lymph nodes. We harvest 3 lymph nodes, at least 3. If the lymph nodes are negative of any cancer, then the patient does not require further axillary lymph node dissection. If they have, if the lymph node is positive but only has micrometastasis, and also these patients do not require any axillary lymph node dissection. If there is 1 or 2 positive lymph nodes, also, we do not continue to do axillary lymph node dissection. We only continue to do axillary dissection if the patient has more than 3 or more positive lymph nodes. And I'll explain to you, I think you'd wonder, why would you not do axillary lymph node dissection in a patient who has 2 positive lymph nodes? I think I would explain that, but of note is that axillary lymph node dissection has its own, it's related to morbidity, and also the risk of nerve injury increases when you do axillary lymph node dissection. And then another indication for doing the axillary lymph node dissection will be if you cannot identify any sentinel lymph node. And I must mention, using a dual method to try and identify the lymph node increases the yield of the axillary sentinel lymph node. So there is this study, this randomized trial where they had over 800 patients, where they compared patients who had 1 to 2 positive sentinels, they randomized the patient either to observation or continuing with axillary lymph node dissection. And this is an old study, but however, this is quite a landmark trial that proved that despite the wild belief that if we remove the axillary lymph nodes, it improves the patient's survival. However, this study proved that patients who have limited lymph node metastasis, meaning who only have 1 or 2 positive lymph nodes, do not benefit from axillary lymph node dissection, meaning their survival rate is similar to those patients that undergo lymph node dissection. So looking at the morbidity that's associated with axillary lymph node dissection, these patients are not offered lymph node dissection. And then now for these patients, remember I said plus minus chemotherapy, plus minus radiotherapy. Is there a role for chemotherapy in patients with early breast cancer? Historically, all patients who had a positive lymph node were offered chemotherapy. However, chemotherapy as well has quite significant side effects. So now, not all patients who have a positive lymph nodes will be offered chemotherapy. So chemotherapy will be offered to patients who have 3 or more positive lymph nodes, or the patients who have those who are lymph node negative, but the tumor biology is that of an aggressive tumor. Like, for example, those who are triple negative, grade 3 tumors, those who are HER2 positive in the absence of targeted therapy. If we do not have Herceptin, then these patients will be offered standard chemotherapy. But the current practice, which is not accessible to us currently in public sector, is that you can do gene expression assays to check whether your patient will benefit from chemotherapy or not. Will they check the oncotype DX? If the patient score more than 11, then this patient, if the score is less than 11, then that patient will not benefit from chemotherapy. That means this patient can be offered hormonal therapy and the outcomes would be similar. We can check the recurrence scores and think here you find that patient with a recurrence score of more than 25, those are the patients that will qualify for chemotherapy. And there is literature to support that. The Taylor treatment trial, as well as the MIND-X trial. Both these studies support the fact that endocrine therapy is equivalent to chemotherapy in patients who are HER2 negative, as long as they're ER positive and the oncotype DX score is less than 11, or the prognostic factor is less than 25. Now, with patients who are stage 2, so this is still early breast cancer, but because stage 2 also includes some T3 lesions, so the tumor mass can be slightly larger. How do we manage these patients? So these patients are offered neoadjuvant chemotherapy, and this is meant to downstage the tumor in order to make it amendable for breast-conserving therapy, meaning for wide local excision. However, if you're going to do this, it's important to mark the tumor either with a permanent ink or a radio opaque clip, so that when you are monitoring the response, if the tumor happens to shrink or disappear, you are still able to locate the site of the tumor to do the wide local excision. Of note, this will work, the tumor to breast ratio is very important. Sometimes in a patient who has a T3 lesion, but they have significantly large breasts, you are still able to do breast conserving therapy. But a similar patient can have the same size tumor, but because their breast size is smaller, sometimes you are unable to do this. You can influence your decision as to whether you continue with breast conserving therapy or not. So these patients are monitored for the response to chemo. That can be done either clinical or radiological with your imaging of choice, depending on your availability. Those who respond poorly to the neoadjuvant chemo will move on to get a modified radical mastectomy, which includes removal of the entire breast plus the nipple areola complex, as well as doing an axillary lymph node dissection. Those who respond well to chemo, meaning that the tumor size will shrink enough to allow for breast conserving therapy, will move on to either wide local excision plus axillary lymph node dissection, or this patient can still be offered wide local excision plus sentinel lymph node dissection. But then there is a question now of the sentinel lymph node biopsy after chemotherapy. And this has been proven as well that because there were questions, is it safe or not doing a sentinel lymph node biopsy after chemotherapy? So I think it's been deemed this, there's literature that support that it can be safe, provided, I think I'm just gonna skip through this, provided, I think the SENTINA trial can summarize everything. So that sentinel lymph node biopsy after chemotherapy is safe and it is accurate, provided that you harvest 3 or more lymph nodes, and this can be done by using a dual method of trying to locate the lymph node, meaning using both dye and the radioactive isotope to locate the lymph nodes. So it is safe. So now I've said we are trying to move away from doing mastectomy, meaning we try to preserve the patient's breast if possible. But are there any contraindications? Is there any reason why we cannot preserve the patient's breast? So yes, there are contraindications. There's some that are absolute and some that are relative. For example, if there is contraindication, so if you're going to do breast conserving therapy, adjuvant radiation is mandatory. So if the patient has contraindication to radiotherapy for whatever reason, either because they are pregnant or they just don't want to do radiotherapy, it's a personal choice, or there's another reason why they have a contraindication to the radiotherapy, that patient cannot be offered breast conserving therapy. If there is diffuse malignant appearing calcification in the rest of the breast, because those are suspicious. If the tumor is multicentric, meaning more than one quadrant of the breast is involved, then you would not have enough breast tissue left behind. Then this patient will be offered mastectomy. And as well, if the patient has persistent positive margins, meaning you would go on to do a wide local excision, check if the margins are clear, you find them positive. If you re-excise and the margins remain positive, then this patient might as well be offered a mastectomy. Then you would decide there whether the patient is getting a mastectomy plus axillary lymph node dissection or mastectomy plus sentinel lymph node biopsy. Other relative contraindications is the prior radiotherapy to the chest wall, increased tumor to breast ratio, because then this tumor can be downstage with chemotherapy to make it amendable. If there's a patient has a genetic predisposition to cancer or something, because the chance of recurrence is higher. But this is all relative, because then the patient can still be monitored. It's only the absolute contraindications that are important. And then when we talk about the management of locally advanced breast cancer, which is the T3N1 or stage 3A, stage 2B, stage 3A and above, up to stage 3C, these patients are offered neoadjuvant chemo to downstage the tumor, either to make it amendable for modified radical mastectomy or for breast conserving surgery. Because according to the NCCN guidelines, even patients who have locally advanced breast cancer, if they respond well to chemo, you can still offer them breast conserving surgery if it's possible. And patients who respond well to chemo, like I said, they will move on to having either mastectomy with axillary lymph node dissection, plus adjuvant radiotherapy, plus minus hormonal therapy. Those who don't respond well to chemo, I think the oncologists know what to do with this. They either will be given different regimen, or they will start another cycle, or preoperative radiotherapy is also possible. But also another option is to move on to surgery and remove the lesion. But most of the time you find that this would not be an oncologic resection because maybe the tumor is large or is attached, and then there will be tumor left behind, and then that will be a toilet mastectomy. Now, of all of those treatments, if the patient has received treatment for breast cancer, how do we manage breast cancer recurrence, especially if it's local recurrence? So the management of recurrence depends on what the initial management was. So if this is a patient who was previously offered breast conserving therapy, plus radiation therapy, then the patient will have to go for a mastectomy because we cannot repeat the radiotherapy again. So we can't offer re-excision. So if the patient received breast conserving therapy before, but they did not receive radiation in the first treatment, then this patient can be offered re-excision of the mass, meaning another wide local excision plus axillary lymph node dissection or sentinel lymph node biopsy, then radiotherapy. And so it will depend. If the patient was offered a mastectomy before and they have recurrence of breast cancer on the chest wall or on the tumor bed, if it's possible, the patient can be offered re-excision if the lesion is excisable. Otherwise, the patient can be offered second-line chemotherapy or radiotherapy. So it all depends on what the initial treatment is as to what we do next. In terms of metastatic disease, so these are patients who present with stage 4 cancer that has already spread to distant sites. So this again, it requires multidisciplinary team involvement, and then the oncologist would offer the patients, depending on the presentation, the patients themselves, the clinical status. Sometimes palliative surgery is performed, especially if the patient has a large mass, or if there is ulceration, or the tumor is bleeding, or there's a foul smell, then palliative surgery is performed. Even when you are aware you will not remove all of the cancer, but for the comfort of the patient and for hygienic purposes, palliative surgery can be performed. Chemotherapy and hormonal therapy can also be used for palliative in the palliative setting, as well as targeted therapy. Most importantly, psychological support for the patient, and pain control is very important. Other things that I did not speak about, the role of immediate and delayed reconstruction for breast cancer. It's also a topic that's quite important, because body disfigurement is it's something that can affect the patient's social and psychologically as well. So it's something I think people can go check it out. We don't have enough time to go through everything. But in conclusion, if we were to remember something from this talk, is that when we speak about breast cancer, early detection saves lives. The triple assessment, if anybody comes to either the local clinic, GP practice, or wherever your office is, and the patient has a breast complaint, if they are offered a triple assessment, you are unlikely to miss anything. Because if you miss it on the clinical examination, the radiological findings will find it, and the radiological report will guide you to the next step, whether this is a patient can be observed, or this is a patient who needs a biopsy. And if you need any type of biopsy, then the pathologist can confirm for you. Staging is important for us to prognosticate, and always approach the management of these patients as a multidisciplinary team. It's quite, it works better when the patient is treated by the team, unlike when the patient is referred up and down to different people. And then it's also very important to treat every patient as an individual, meaning as much as there is guidelines to treat certain patients of a certain stage with certain treatments, sometimes you have to individualize the patient, the treatment based on the patient that you're dealing with. So it's very important to treat every patient as an individual. Thank you very much for listening.